Hello, everyone, and welcome to today's Center for Healthcare Strategies webinar, Embracing Tech-Enabled Innovation in an Evolving Medicaid Environment. This webinar is made possible through support from the Helmsley Charitable Trust and the Public Benefit Innovation Fund at Digital Harbor Foundation. I'm Kelsey Breichman. I'm a Senior Program Officer from the Center for Healthcare Strategies, and I'm delighted to welcome you here today. I hope that you enjoy today's event. At the end of the session, a brief online evaluation will pop up on your screen. Your feedback is very important to us, and we will take a moment to complete the survey. Next slide. So, during today's event, we'll learn about 3 pilot projects addressing health-related social needs implemented through the Medicaid Innovation Collaborative. MIC convenes states and health plans to identify and support the adoption of tech-enabled innovations through a multi-state learning group. CHCS is a partner organization with MIC. After introductions and an overview of MIC, pilot project participants will provide an overview of how Farmbox RX, Kaizen Health, and Samaritan partnered with Medicaid health plans to implement new approaches for addressing health-related social needs. We'll then have a panel discussion about lessons learned from these pilots and open it up for audience Q&A. Next slide. So please feel free to submit questions throughout the webinar by clicking the Q&A icon at the bottom of the screen. We'll be reviewing these and addressing them towards the end of the webinar as time allows. Next slide. So here, for those of you who aren't familiar with us, we have a bit more context on who we are at the Center for Healthcare Strategies. CHCS is a nonprofit that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for those served by Medicaid. You can find more information and resources on our website. Next slide. So, in terms of today's topic, why focus on tech-enabled innovation in Medicaid? Historically, companies providing tech-enabled solutions have focused more on Medicare and commercial than Medicaid markets. With this in mind, it's important to ensure that Medicaid populations have access to new, beneficial tools and models as innovations arise. Additionally, we're currently in a challenging policy environment for Medicaid. As states and other Medicaid stakeholders face growing budgetary pressures, implementing tech-enabled solutions is one potential strategy for effectively and efficiently meeting Medicaid member needs. So with that, I'm going to pass it to my colleague, Leona M, Executive Director at the Medicaid Innovation Collaborative, to provide an overview of our work at MIC.
Thanks, Kelsey. As Kelsey mentioned, if you want to go to the next slide and the one after that, as Kelsey mentioned, tech-enabled solutions have historically focused on commercial and Medicare populations, but we know there's a critical role that these solutions can play to improve the lives of people on Medicaid. However, as many of you know, Medicaid is complicated, complex, and selling into Medicaid can be challenging for many of the companies, which makes it hard to scale the solutions across the country. Unlike a contract with a commercial or Medicare population, Medicaid obviously is state by state. Each state has different policies, regulations, and then within each state, the state contracts with multiple managed care plans or health plans, and that varies greatly by state. So for example, in Iowa, there may be only 3 managed care plans, where a state like California could have up to 24 plans. These managed care plans then negotiate with providers or startup companies for their services. But even if you were to contract with Molina in Kentucky, it doesn't mean that translates to a contract in another state. On top of that, there's hundreds, if not thousands, of innovations for plans and for states to sort through, and it can be overwhelming to find the best solutions to meet the members' needs in their states. So the next slide. So that's why one of the reasons why we started the Medicaid Innovation Collaborative. We launched it in 2020 by our team at Acumen America, which is a nonprofit social impact investing firm focused on tackling poverty with a focus on improving the health of low-income Americans. What we've been learning is by working with state Medicaid programs, managed care plans, and entrepreneurs, we're able to identify, implement, test, and really learn about what are the solutions that make a difference for Medicaid populations. We've now implemented the program in 9 different states. We've completed it in 6 states, addressing health-related social needs, behavioral health, and just recently launched the program with our last states in Colorado, New Mexico, and Virginia. But today we're going to focus on the experience of the pilots we conducted in Iowa, New York, and Kentucky, which really looked to identify solutions to address some of the challenges around food and nutrition services, housing, and transportation. And the next slide. To give you a sense of how the model works, and this will just give you a little bit of framing for the discussion today, the program focuses on 3 key phases. First, we root whatever we're working on in really defining and discovering the problem. We engage state Medicaid leaders who align priorities with those of the managed care plans in the states. And also bring in the community voice, which we believe is critical to ensure that both the problem that we're defining is clear and rooted in the experience of consumers, and that the solutions are relevant to the Medicaid beneficiaries in the state. The next step is we identify and assess the company solutions that support these goals. So we do this through a request for information. We source solutions that are out there that are relevant to those needs. So for this last cohort that you're going to be hearing from, we started when we were looking for solutions that would work in Kentucky, Iowa, and New York. We uncovered over 100 solutions, but then used a structured process where we got input from state leaders, plans, Medicaid beneficiary to narrow down to the companies that had the most relevant solutions that were appropriate for Medicaid populations. Lastly, we put on host a showcase event where we highlight the most compelling solutions to address the needs. So, for example, addressing food, housing, transportation. And then figure out which are the ones that are most interesting to pilot, which ones resonate with the plans, and then help guide a process where we implement these solutions and evaluate which ones work in context with an external evaluator. So those are the solutions that you're going to be hearing about today. And again, wanted to thank our funders, the Leona M and Harry B. Helmsley Charitable Trust and the Public Benefit Innovation Fund at Digital Harbor Foundation. So with that overview, I'll turn it back over to Kelsey and to set the context to learn more about the pilots and experiences in implementing these solutions.
Thank you, Enid. Now I'm excited to welcome today's panelists and presenters. Here to discuss the Farmbox, next slide, please. Thank you. Here to discuss Farmbox RX and Passport by Molina's pilot in Kentucky, we have Megan David, Chief Commercial and Operating Officer at Farmbox RX. We also have Stephanie Stone, Assistant Vice President for Healthcare Services at Passport by Molina Healthcare. With us to discuss Kaizen Health's pilot with Iowa's 3 Medicaid MCOs is Mindy Kniebel, Chief Executive Officer at Kaizen Health. And finally, here to discuss Samaritan's pilots with select health plans in Kentucky and a health plan and care coordination organization in New York are Ariel Cooper, Chief Operating Officer at Samaritan, and Tess Purcell, Customer Success Lead at Samaritan. And with that, I'll pass it to our presenters to give an overview of their projects and initial outcomes. I believe we're starting with Farmbox.
So this is Stephanie Stone from Passport by Molina Healthcare, and I will kick us off and then pass it over to Megan. When we were preparing for this pilot program from the health plan perspective, we knew almost immediately that we would be seeking a solution that was addressing food insecurity. Food insecurity remains a persistent issue impacting Kentuckians, including our members in the Medicaid space. And evidence shows that food delivery combined with health coaching can have a positive impact not only in addressing food insecurity, but in improving health outcomes for individuals with certain chronic conditions such as diabetes. We reviewed our available HEDIS data internally and applied multiple filters such as gender, race, age, and location. And through that review, we identified disparities in HbA1c testing and HbA1c control within our membership in some zip codes in Louisville, Kentucky. And that was compared to other Louisville zip codes and others in other regions across our state as far as those outcomes go. So due to those identified disparities, we decided to focus our pilot on individuals with diabetes living in those zip codes. We knew we wanted to begin with 200 members in the program. We wanted to prioritize outreach to members who were insulin dependent. We selected Farmbox as our partner for this program because of their experience working in the food insecurity realm, but also their experience working with health plan members with diabetes. And they had previously gotten great results with another Molina health plan in New Mexico. So that set them up for success with us from the beginning. You can see on the slide on the right an overview of the solution we offered with home delivered food boxes, educational materials included in the boxes, and telephonic coaching calls to participants. And that we had 165 of those 200 members complete the program at the end of the year. I'm going to turn it over to Megan now so she can share more information about the specifics of the program as well as our program outcomes.
Amazing. Thank you so much, Stephanie. We can go ahead and flip to the next slide. But as Stephanie mentioned, we were extremely excited to have the opportunity to partner with Molina Passport on this program and serve their members in the state of Kentucky. And we're even prouder of the outcomes that we were able to report from this activation within the Kentucky population. I think most notably is proving a clinical A1C improvement of 10 percentage points in test completion and a 28% clinical compliance rate with the A1C below 8 among the pilot enrollees versus the control group of only 24%. So a 4% percentage point improvement there. We also saw really strong testimonials coming from members around their perception of their eating habits and their ability to maintain and improve their ongoing condition management through lifestyle and behavioral changes. We had members reporting that they were trying new foods for the first time, notably pomegranates, grapefruit, and kale were noted in some of the member feedback coming through the participating populations. But we also saw some pretty tangible improvement in both perception of mental and physical health. From individuals reporting better eating habits and feeling more confident in the management of their blood sugar control and their understanding of their chronic disease management. Can go ahead and jump forward. And I think we're passing it off to the Kaizen Health team.
Good afternoon, everyone. My name is Mindy Kniebel, and I'm the founder and CEO of Kaizen Health. And I'm here to talk to you about the transportation project that we did in Iowa. This is very near and dear to my heart because I actually grew up in Iowa. So it was quite an honor to serve the folks of my home state and where all my family still lives. We were able to work with all 3 of the MCOs in Iowa, which was a lot of fun to be able to bring everyone's different thoughts to the table. I'm going to tell you a little bit about transportation. I started Kaizen 9 years ago because my own family struggled with transportation, but I came to learn that it's not just my family. Every year, 3.6 million adults miss or delay medical care in the U.S. because of transportation barriers. And specifically for Medicaid in 2018, over 2.5 million people, which is a little over 5%, reported that they were delaying care because of a lack of transportation. A couple other stats, because I'm a data nerd. There are several studies that have shown that 25% of missed or rescheduled appointments are due to a lack of transportation, and the total missed appointment or no-show appointments cost our country $150 billion every year. One last step for you: for every dollar we spend in NEMT, we yield $11 in savings. So it's a great investment across the healthcare system at large. So what we did, so Medicaid transportation has largely been riddled with a lot of rules and regulations, and it was really great to be able to throw everything sort of out the window. So we worked with about 200 folks across the 3 health plans, and worked to get them, of course, to clinical care, but also to non-clinical needs, because only about 20% of our health outcomes are tied to clinical needs. Next slide. So I know this is a little bit of an eye chart, but the sort of categories of rights, so typically in Medicaid, and this is kind of being generalizing across the country, you can get to healthcare appointments and usually pharmacies, and then there's some variability state by state, as it was mentioned earlier. But for this demonstration project, we had clinical folks, so you go see your doctor, you could go to a vision appointment, dental, etc. Pharmacy, accessing food, so grocery stores, farmers markets, food banks, fighting social isolation. So that could be visiting family and friends. It could be going to a faith-based organization, lifestyle, going to parks, going to work out at a gym, and other fitness reasons, housing. So really looking truly across the social determinants of health. But there's really one major thing I want to point out, because this is, coming out of Washington right now, are potentially some requirements tied to Medicaid around having employment or being engaged with employment processes. And we showed that by providing transportation through this demonstration project, that it can be very, very successful. So we have long worked in the upskilling and getting to job interview space through other nonprofits we work with today. But with this demonstration project, we got folks to upskilling, to interviews, and then they were able to use their transportation to get to their job. And we actually had 2 folks be able to save up enough money during that time to actually purchase their own vehicle, which is such a big win. Growing up in Iowa, like, I know how much driving you have to do. Public transportation is very minimal. So it was really great to see 2 folks go all the way through the process and truly solve the problem. Now they have transportation for whatever they need. Thank you. And I will pass the baton on.
Hello, everybody. I'm Errol Cooper, Chief Operating Officer at Samaritan, and I'm joined by Tess Kersel, our Director of Customer and Partner Success. I'll be taking the presentation, and then she'll be joining me for the Q&A. First, we are just so thrilled to be a part of the MIC and represent our collaborations today with Humana, Aetna, Health First, and the Staten Island Performing Provider System, SIPS. So as my panel peers have done, I want to ground us first in the challenge that we're trying to solve. Individuals experiencing housing insecurity are among Medicaid's highest need, highest cost members, with annual costs ranging from $30,000 to $50,000 per person, which is about 5 to 7 times higher than their housed peers. These high costs are a reflection of unmanaged chronic conditions, unmet behavioral and social health needs, and frequent emergency department use. So it's clear that housing stability is bad for your health, and in part, this is because it is so difficult to engage in much needed care when you need it. Phones are lost, addresses change, people don't have the bus fare to make it to those critical appointments, as my colleague just shared. Which means that typical outreach is often ineffective. And while the most direct solution to provide housing would be ideal, it's typically cost prohibitive and logistically really complex to deliver within Medicaid. So there's been this gap between what people need and what the system can deliver, and that is where Samaritan has stepped in. Samaritan aims to close this gap by providing direct critical financial and social support to unhoused Medicaid members to increase their engagement with health and social services and to overcome barriers to care. We work by partnering with community-based organizations and care teams across the health system who use our digital platform to sign up unhoused Medicaid members and create clear action steps, things like completing a PCP visit or visiting a food bank. Members then receive financial bonuses for completing these next steps, which they can use to overcome barriers to care, like paying for that bus fare or covering their utility bill. We also provide social encouragement in the form of text messages to support the dignity and motivation of our members. Through the MIC, we partnered with Health First in Staten Island and SIPS in New York and Aetna and Humana in Kentucky to collectively offer 300 Samaritan memberships to high-need unhoused members. Next slide, please. And we're really proud of those results. We have additional results. Actually, we're reviewing our 6-month pre-post with Humana and Aetna tomorrow. So we will have additional data soon for Kentucky. But from our preliminary analysis of our New York pilot, which included 81 Samaritan members, we saw that Samaritan facilitated strong care coordination and member engagement, which resulted in a 91% completion rate of those case management next steps, which translated also into a 94% PCP utilization rate among Samaritan members after the intervention. From our additional third-party evaluated work in California, which was separate from the MIC, we saw that these early engagement trends translated into a 91% reduction in ED utilization and a 54% reduction in cost of care. So we're really excited to dig into the final evaluations for both of our work in New York and Kentucky. I do want to highlight some of the lessons that we've learned because we now have implemented Samaritan across 5 different states. First is that integrating with IT systems is a huge boost. We hear this all the time, how critical it is to integrate with existing systems. We were able to do this with our work in New York, and it really helped us identify folks who were already unhoused after completing that health risk assessment, which really expedited our efforts. 2, ongoing commitment from all of our stakeholders has been really critical to help us ensure that we're meeting our intervention goals. As a vendor, we have access to our own data, our platform engagement data. We're able to see how folks improve their health and housing, but we really are dependent on our health system partners to determine if this translates into those meaningful health utilization changes, which we know are going to really move the dial into expansions and ongoing innovation work. And 3, we've seen how critical it is to integrate into existing networks of care to effectively serve the Medicaid population. So that's why for Samaritan, we were really deliberate about not becoming a provider, but seeing ourselves as an accelerator of existing health and human services so that unhoused members can more effectively access the care that they're trying to reach. And that's it. I will pass it over to Kelsey.
Thank you so much, everyone, for those excellent overviews and a description of the successes you all have seen to date. It's great to hear. Now I'm going to move into our panel discussion, where I'd really love to dig a little bit more into the how of these pilots and understand a bit more kind of what lessons you all have learned and what others who are interested in implementing similar programs might consider or take away from what you all have learned. So I welcome all my panelists to join the video. Thank you so much, everyone. So for our first question, would love just to hear a little bit more about, what aspects of your pilot implementation approach were most successful? What were the pieces that were really critical to achieving some of those successful outcomes that you all just shared? And perhaps let's go in the same order as the presentations. Maybe let's start with the Farm Box Molina folks.
Sure. I'm happy to kick it off, and then Stephanie, happy to pass it over to you. I would say from the Farm Box RX perspective, really supplementing that condition appropriate health literacy, and going beyond just providing the condition appropriate food delivery, but really engaging the members and educating them on how to care for their diabetic condition, and really give them the tools and in a very engaging way to educate them on the types of foods that they should be eating, and what their A1C should look like, and how frequently they need to go in for that testing. Was really a key component of this program.
I would agree with everything that Megan said, and I would also just add from kind of the macro level of implementation. One of the things that worked so well with this pilot was that Passport and Farmbox RX started early. We began our implementation process 5 months before our go live date. We were meeting multiple times a month. We had our eyes on every piece of what this needed to look like to be successful, from the clinical programming to the contract between the two of us, to getting approval for the member educational materials that has to go through our state Medicaid regulatory body. And we kept really strong and open lines of communication from the beginning and throughout implementation, which allowed us to really keep a pulse on how things were going. We were able to make adjustments midway through, based on our own observations or feedback we received from members. And I think because of the strong partnership, this was incredibly successful. We work with multiple partners, and I will give Farmbox RX credit for being a great one in this space and really being proactive in making sure this was successful.
Thanks, guys. Mindy, I'll pass it to you for your thoughts.
Yeah, so I think the involvement of the state Medicaid office was so critical to our success. Really interested in changing policy, which was, a lot of what we were trying to demonstrate. And so I think, having all three MCOs, so the whole state, Medicaid folks were involved. And I think that was really the key to the success of our program.
I really echo what my panel peers have shared. And I think that focus on pre-launch planning and really getting all the stakeholders together, and through the MIC having the state at the table, was really effective to getting our, the approvals and through the regulatory bodies. What's really unique to Samaritan is this network of community-based organizations and care teams within actually all of our MCO partners that we were able to bring together, and to start providing a value to them immediately, both those care teams having a tool that can start incentivizing behavior, and then for the Medicaid members that we were reaching, having something that translates into a hot meal or an immediate benefit for them. And then I think this, unique combination of financial and social support that we're providing, I think, Megan, it kind of speaks to what you were saying. It's not just a platform that's effectively reaching folks, but we're also connecting with them on this peer-to-peer level to kind of address some of their social needs and that isolation that comes from being unhoused. And hopefully through that, getting to boost their motivation and engagement with critical services.
Great, thanks. One thing I want to kind of drill down on a little bit is that partnership piece, and some of you started speaking to that, but just wanted to ask if folks have any further thoughts on what factors really contribute to successful partnerships between you and between companies, plans, the state. That's really so critical to all this.
I would add to what Stephanie had mentioned in our relationship with Melina throughout this process is an openness to make changes based on what we're seeing in flight during the program as they're needed, right? And so that's where those touch points became very important for us on an ongoing basis, is really being able to modify whether it's delivery schedules or types of food that members were preferring and utilizing or had a preference to utilize on an ongoing basis. We were able to make those changes to continue to increase or maintain the level of participation that we saw. And I think that that very much contributed to the positive outcomes that we saw at the end of the program.
Yeah, I agree. And adding on to that, I think that getting really clear with what the challenges each stakeholder is trying to solve, and then making sure the intervention is providing a solution to each of those stakeholders' challenges. We're not going to all be bought in if there's only one stakeholder that's benefiting from participating in an intervention of this size. And so I think those logic models of getting really clear of like what are going to be the early wins for maybe on the ground implementers, what are going to be the more long-term wins for the MCO and health system, and mapping that all out. And then again, sharing and reflecting back impact, pivoting where necessary and on an ongoing basis was really effective.
Great, well, thank you. So for my next question, I want to explore on the flip side of all that, which is, what pieces of these pilots were most challenging? And is there anything that you all would change about your approach going forward?
Again, I can start with this one. So as part of our pilot program, we at Passport offered live sessions for our members. They were optional. We incentivized members to attend with food and small gifts. We offered bus passes. We offered free childcare on site for attendance. And we called members, all 200 members every single month, to ask them how the program was going and invite them to the live session, remind them that it was being held and that we would get them free transportation if they needed it. And those sessions were incredibly low, had incredibly low attendance. We're talking 5 people max at any of the sessions out of the 200. And these were held at the Dare to Care Food Bank within one of the zip codes, these very clustered zip codes in West Louisville. So within easy reach from a distance perspective for our participating members. And I think what we learned is just from talking to members through the year, post-COVID, they don't want the live sessions. They don't even want virtual sessions. We struggle to get them to come to other educational sessions not related to this program. They like text communications. They like phone call communications, sometimes emails. They want things at their fingertips instead of having to have that face-to-face live approach. So we have to be more creative moving forward. We won't use live sessions or even virtual sessions in the future. We got great outcomes even without members attending those sessions.
I would say with regards to the transportation, communication was definitely key. One of the main population that we worked with did not have transportation as a benefit with their Medicaid plan. And so it just wasn't something that they were used to using or, super knowledgeable about. I think we could have done a better job of more frequently reminding them, sending them the text message that Stephanie just mentioned in their language. We offer a lot of communication. It can be an email, a voice call, or a text message, and we have like 55 languages in text and about half of that in voice. So getting to people how they want to be communicated to, like Stephanie was just speaking about, but also in the language that they want to be spoken to in is really important. And I think making that more frequent than we did for the outreach as a whole, whether it was, the health plans, us, whoever was reaching out, it should have been more frequent.
One of, I think, the implementing challenges that we encountered, besides just that each state truly is its own entity with its own benefits and challenges, really finding these unhoused Medicaid members and then making sure that they were insured and covered by the plans that we were partnering with was a challenge for our community-based organizations. Oftentimes, they were maybe providing career coaching at Goodwill, or they were transitional housing at Arthur Street Hotel. And those programs and services hadn't previously been tied to being insured by Aetna or Humana. And so by partnering with Samaritan, we were now asking them to kind of check insurance status. And we did face challenges early on with folks enrolling, members that they thought were covered and then actually weren't covered. So we had to, implement a new process where we were kind of getting that checked in platform so that we could ensure we were reaching the right folks. Definitely something that Mindy, it sounds like your team was able to effectively do with getting all the MCOs at the table is something we're really excited to be moving forward in Kentucky through an all-plan pilot next year. So because anytime a case manager is needing to go through an additional layer of a checklist to see if someone's eligible for this benefit or not, we know that that slows down the solution really reaching people. And so definitely excited to be navigating that in a new way next year.
Thank you, everyone. So for my next question, and building on some of the themes that you all have begun to raise, would love to hear more about how you all work to engage with and really to build trust with Medicaid members that you're serving.
From our perspective, it wasn't just helping our members identify the issue and escalate that need to Melina, but actually supporting in closing whatever gaps they had. I know Stephanie had referenced, providing access to transportation to get them to some of those in-person events. I mean, that's one example. But really, as we were identifying any gaps that members had to either getting to their care appointments or staying on the medications that they were prescribed, we weren't just identifying that need, but we were helping them with getting enrolled in mail order pharmacy or getting them connected to rides. And really having that closed loop experience so that members felt like they had that surround sound support to really manage their ongoing condition.
So what Megan said was that we as a health plan sent out postcards at the very beginning of this program, right at implementation, saying, hey, we are partnering with Farmbox RX if they call you, this is legitimate, basically. A lot of Medicaid recipients are suspicious of additional folks that are calling them. They're worried it's a scam. We all live in that scam heavy world now. So just to give the heads up that you're going to be contacted by this group. And yes, when they say they're working with us, they really are, and it's okay to talk to them. I think that helps to kind of open the door a little bit. But I also want to say Megan's team had the same small team of outreach folks calling our members all the time. It wasn't this huge call center where you might get a random person every time contacting you. They're familiar voices. They're people who they believe knew them. And I think that goes a long way in addition to help solve those resource needs that Megan was talking about. And then, as I mentioned earlier, we had 3 team members who were calling these members every single month too to say, how is your program going? Are you having a good experience? And when there might have been less than 5 members said either they didn't get their food or something wasn't fresh in one of their boxes, we were able to connect right back to Megan's team and get a new box shipped to them right away to solve their problems. So they really felt like, I think these members felt like they were really being taken care of from both sides with this partnership. And I think that led a lot to their trust and engagement.
From the Samaritan perspective too, I think, Stephanie, what you're mentioning is really critical to our work as well, where we were deploying Samaritan through a network of partnerships that our members already knew. They had their trusted face that they were already accessing care through. And then what we did was then put an immediate value add in the hands of these really skilled relationship builders on the ground who were already really closely connected with the folks that we were serving through our platform. And that ended up being a huge benefit. And then also having this piece of an unconditional social and peer support to show up consistently to encourage and validate the experiences of the folks who we were serving, and leading with dignity and respect, meeting folks exactly where they were all really pivotal, I think, in getting folks to feel really cared for and bought in, exactly like you're mentioning, Stephanie.
Fantastic. So I think I know I'm seeing here that we have a number of audience questions, so I'll start going through a few of those. And before I do, I want to just again remind folks who are on the line that you can use that Q&A button at the bottom of the screen to submit any questions that you have. So looking through the question list here, I think one of these picks up nicely on, I think it was Ariel at the beginning who was talking about the importance of integrating different systems. So one of our participants asked if any of you have interacted with community information exchange and referral platforms like Find Help or Unite Us, and are there ways that that helped or hindered your work? So curious if any of you have experienced that.
I can jump in there. We've been in conversations with Find Help for a while to find an opportunity to integrate, because we know that a lot of the teams that we are partnering with might be already using that in their work. So they have an unhoused member, and then they're going to make a referral to a housing navigation team. What often happens is that a referral is made, but knowing if that is actually completed is really difficult. We're all familiar with that. And so what Samaritan right now does allow is for those teams to add a financial bonus to completing that referral so that it's more likely to happen. Really the next step and the North Star is to have those systems talk to each other. So it's not a CHW making referral and Find Help and Unite Us, and then updating that as an action step in Samaritan, so that a member can receive a financial bonus, but really having them seamlessly integrated. So it is the North Star. We know that teams are using them, and this is, again, where we're trying to build on and accelerate what already exists rather than being in competition with that. But it's also, I think the integration is important for the sanity of those teams on the ground who have now so many different tools, and we want that to be more streamlined for them.
I would add that we have integrated with a couple of those referral platforms or sort of aggregator platforms out there. The challenge being you have to have contracts with all these different MCOs, right? You all have to be working with all the same clients. And so having the integration and getting the eligibility files and doing all the things and having that like move smoothly through everything is no joke, right? And we're all always updating our technology on top of that. So it is not as easy or as clean as one might think, but I think that is where we need to go. We just need to figure out a way to maybe, I would love to see all of us like working together with the same MCO, the same member population. You know, I'm hearing and I'm very familiar with these companies, obviously, but you know, if we could all sort of wrap around all these services, you know, around these members, the impact that we could have would be amazing. And, you know, that's sort of the point of those platforms, but there's a lot going on there. So.
Great. And so I have another question here that really again builds on the theme of just being a member centered in our work. Someone asked for members who aren't strong technologically or who don't have internet access, what methods were used with participants? I'm curious if folks have kind of experience in this area.
Well, under our program, we did a lot of telephonic outreach, both coming from Farmbox RX and coming from Molina directly to the member. We also were using snail mail or USPS, as well as that supplemental in-box health literacy material. So we actually took a very digital light approach intentionally. In the way that we run a lot of our programs here at Farmbox RX, where we're able to meet the members where they're at in their home, and give them that editorial style, condition-specific material, and material around other benefits and services that they have access to, where they're able to engage with it on their own time, and in a very low-tech way.
Yeah, echoing what Megan said, for the folks who received a Samaritan membership, we're primarily keeping up to date on their membership via text message or email. In New York, additionally, they did some outreach via snail mail as well. And so I think being flexible with the fact that people have different access to technology was really center to our approach when we were trying to reach folks who may have inconsistent access to some of the technologies our teams may have access to regularly.
I recently was looking back at some really old stuff from when we first started the company, and I thought it was really cute that I thought everyone would be able to get a text message, based on my dream scenario that I was drawing on a whiteboard. That's not true. I knew nothing about transportation getting into this space, but what I quickly learned is that, mobility issues often go hand in hand with small feet mobility issues. Is not just, a broken hip or a broken leg or something, somebody's permanently in a wheelchair. And so they may have caregivers. So you have to really think about like, what's the best way to reach this person? And a lot of times if they're living in a nursing home, right? Or they are living with a family member. They may have a caregiver. They might not even have a cell phone or a home phone, but their caregiver does. So you have to be very creative in how you're reaching out and who you're reaching out to and making sure you're getting all the right folks engaged.
Thank you for that. So I have another question looks like this one's for Stephanie, which is when plans like Melina are making strategic evaluations of vendors, how do you assess and prioritize patient experience with those solutions?
The patient experience or member experience is really important, of course. When we're looking to onboard with a new vendor, we're going to ask for information. In this case, with Farmbox RX, they had already partnered with our New Mexico health plan. So we had some firsthand information from another Molina health plan about experiences with this particular vendor. But we're also going to ask for testimonials, data, information from the vendor to tell us, in other places with other groups of people, show us what your experience has been. And that's definitely part of our evaluation process when we're selecting a partner. And then, as I was describing earlier, we ask our members what their experience is. We might mail surveys. In this situation, we were calling them monthly to ask how their experience was. And then both Farmbox and Passport by Molina surveyed members at the end of the year about their experience. We were in part calling to make sure, my team was in part calling to make sure that they were set up with other ways to get food with this pilot program ending. We wanted to make sure that they knew where their local food bank was, how to get there. Did they need us to help them get there the first time, understand what days were the best days to go, those sorts of things. We didn't want this pilot to end with them being left in the lurch. So as part of those calls, we were also asking about their experience, and it was overwhelmingly positive with this particular vendor.
Thank you. So I have another question here that's asking about kind of implementing kind of innovative solutions in states that are really large to have a lot of different MCOs. So maybe helpful way to think about this question is when you all are kind of moving into a new state or a new area, what that rollout process looks like. Do you tend to go in kind of a smaller kind of city? Do you other instances when you've gone into a whole state at a time? What does that rollout process look like?
I'm happy to speak to this because Samaritan has actually been in California since 2022. And it's really been piecemeal, plan by plan, health system by health system, demonstrating our impact and then scaling from there. And so we're working with Anthem Blue Cross, Health Net, Molina in California, and then smaller health systems and Common Spirit Hospital, an FQHC, really anywhere that we can demonstrate our value with a belief that, one, we know this is a population people are trying to serve. People are trying to figure out how to provide additional services to engage unhoused high-need members. And two, we have a solution that works, even though it's very time consuming and resource intensive to evaluate plan by plan and project by project. We're confident in that those results will speak for themselves and that we will have the capacity to scale. I wish that there was MIC for California, but maybe that's on the horizon, Vinu, so that some of the incredible accelerated progress we've seen in Kentucky and New York could come to bigger states like California.
For us, it's whatever our client says. So sometimes that's a, a smaller regional area of a state, and sometimes it's statewide from the get-go, right? So for transportation, it can be a little, we serve 20 end client segments, with most of our work being in the health plan and health system space, but we also work with the justice system, we work with municipalities, clinical trials, et cetera. So again, it's just kind of driven by the needs of the client, but it can go either way, where it could be like, a city, or it could be the whole state, and they're like, yay, the whole state of California all on the same day.
So a great question here that builds on that last question, which is, what are your experiences moving from limited pilots to a wider scale up? And are there any elements of service or coordination that are harder at a larger scale?
I think definitely as we scale up, some of the challenges that we mentioned are amplified, certainly, where if we're working with bigger networks of providers, for example, that means that we have more variety in how they're delivering care, more unique solutions or ways of reaching folks, which means we have to be even more adaptable, even more clear about, use of the platform and the benefit, and being sure we're aligned and we understand each of those providers well, so that we're aligning with what they care about. And so there's definitely the groundwork of that I think tends to be amplified when we expand, cast the web wider.
Building on that, I would say through expansion, we also will wade into dealing with multiple different needs and objectives, right? So because we're working at the population health level, this specific pilot was very focused around diabetic members. But as we expand into other populations, we'll start layering in like maternal health outcome needs or childhood health outcome needs. And so you're focusing on different populations, which comes with, different messaging strategies, different outreach strategies, and even different end products that we're using to incentivize those groups to engage with our programs.
Excellent. Thank you for that. So one more audience question here. And they asked what information needed to be submitted from the companies to MCOs for reimbursement. And I'll start by clarifying that these pilots were funded through MIC, so the reimbursement process here might not be kind of typical or necessarily analogous to if it was done outside of the pilot. But with that said, want to just open it up to see if folks have any additional information to share.
So the MIC funding supplemented this pilot from the managed care perspective, but we were the primary funder for this pilot program. So Farmbox RX submitted a monthly invoice to us, and we paid a per member rate based that was, for their food that they were delivering, as well as the services that they were delivering to the members. So they send us an invoice and we send them a check. Just like we just had to set them up as a vendor in our system, which is a pretty simple process after you get through contracting. The contracting is the long and hard part.
And Stephanie, correct me if I'm wrong, but I don't think we were reimbursed through any type of claim. We were funding it through quality improvement, correct?
Yes. So no claim submissions, just simple invoicing and payment for the invoices is how this was set up.
And that's similar to how Samaritan works with most of our partners. In either there is this early phase of a pilot where there's a fixed amount for reaching a certain amount of members, and that's done kind of over a year. But then typically we invoice per engaged member per month. So folks that we are actively engaged in the platform and who have met with a case manager and met other minimum service requirements that month, then we send over a bill and also nested in that QI fund.
Great, that's really helpful. Thank you. So a couple more questions from me before we close out. Wanted to for Stephanie and Megan, wanted to jump back to you guys to speak a little bit more to how you're building on this pilot going forward and what drove the decision to continue this work.
Yeah, so we're in year 2 together now, closing out year 2. Because we had such great success from a health outcomes perspective with our first cohort, we kind of copied and pasted that, but into different regions of the state. So we looked in other parts of our state where we had those same disparities, just a little bit lesser degree than in our West level zip codes that I talked about earlier. And so we're in more rural parts of the state and kind of all over a little bit now versus being focused in those several zip codes that were clustered together before, but still doing the same work, still, Farmbox is still delivering the food and outreaching our members. We just don't have the in-person component happening anymore.
Great. So a question for everyone, kind of a bigger picture question. So, as I said at the top, I think everyone knows we're in a bit more of a challenging Medicaid environment right now than we have been past. With the passage of HR1 and other federal policy changes, states are facing increasing budgetary pressure. So within this environment, I'm just curious to hear from you all. What opportunities do you see for tech-enabled innovation to support Medicaid in providing more efficient and effective care?
I can start. When I was first starting the company, again, data nerd here, so I did a lot of research, but there was up to 33% fraud in our space. And so I think one of the big things that we can do that will sort of align with some of the initiatives coming out of Washington as a whole throughout Medicaid is to eliminate some of the fraud. And so, as much as whether it's food, transportation, housing, however we can do that, I think will be impactful and well received, regardless of the thing that we're putting forward.
I know on our side, one of the things that we're really leaning into with some of the policy changes that are happening right now is ways that we can support member education and adherence with some of the new administrative like redetermination things and work requirement things. So knowing that going back to trust, knowing that we've already built that trust with these members, we've built the relationship with these members. While we have their captive attention in regards to the food delivery program, how can we make sure that they understand what they need to do and what they need to submit, and how can we be helpful in making sure that they're not falling off from an eligibility perspective because of administrative or paperwork non-compliance.
Mm-hmm.
That's a really big one for us right now.
Yeah, I think similarly at Samaritan, echoing what Megan said, understanding how Samaritan can support MCOs, keeping their members engaged and completing these very bureaucratic steps to keep their eligibility. A lot of those are translating into action steps. And so people are able to use the platform actually to make sure that folks are jumping through those hoops. But I think at a broader scale, we're all feeling the budget constraints and uncertainty. And so I think it's definitely a time to look at validated tools to contain costs. And I think that's where some of the powerful work that the MIC is doing is, I imagine it's going to grow, where we can convene and accelerate what it looks like to evaluate what tools are effective or not. And I think, Mindy, that kind of speaks back to what you were saying about the fraud. There's a lot of really great tools that maybe would work in a different time or a moment or with a different population, but really being discerning with what's going to work for a Medicaid population, what kind of tools are really human-centered to those very specific challenges to close the gaps in care for this high need population. I think there's going to be more scrutiny for that, but hopefully we can start to learn from state to state and from MCO to MCO and have these collaboratives where if one MCO has validated that a tool is effective, that another MCO will be willing to pick that up and try to expand and scale what works.
And I think just to, echo what Megan and Ariel really pointed out, but to say it differently, we've got to do more with less. Right. So all of our touch points have to be more meaningful. They have to come with more. Right. So we did a small pilot in Kentucky with getting drivers certified as community health workers, because Megan talked about trust a lot. That's very important. Right. And if we're taking folks to recurring therapies, not just the one-off discharge from a hospital, but going to, dialysis or oncology treatment, et cetera, you spend more time with those folks than you do with your own family and friends a lot of times. And they're your friends, right? They know more about you. And so how do we do that? And so we're working on a whole program to get drivers certified as community health workers so we can do more with them while we're engaged with them.
Thank you so much for all. Those are all excellent and really helpful examples. I appreciate you all sharing those. And I see we're about at time, so I think that's a good place to end this. So yeah, again, thank you everyone, all our panelists, presenters, for being willing to join and share about your work today. And thank you for everyone on the line for joining the webinar. For more information on these and other MIC pilots, CHCS is drafting a series of case studies that can be found on our website here. And more information on the Medicaid Innovation Collaborative and other solutions and topics we've explored can be found on the MIC website. Thank you everyone and have an excellent day.